Good afternoon. Claudio Gualtieri, advisor with AERP's Campaign for Action, and working primarily on healthcare access, improving access to nursing care, and building social determinants of population health.
I'm Ed Westrick. I'm a primary care internist in Rhode Island and a former pharmacy economist.
I'm Claudia Russ. I'm a gastroenterologist and internist with the Western Connecticut Health Network and a clinical educator.
Steve Kovic. I'm a professor at the College of Pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research.
Brian O'Sullivan. I'm a pediatric pulmonologist at Dartmouth Hitchcock Medical Center and professor of pediatrics at Guy's School of Medicine at Dartmouth.
Jean Meyer, Director of the Connecticut Citizens Health Initiative, which is a health improvement collaborative with the state of New Hampshire and out of the health policy and practice at the university.
Jason Wasser, Vice Chair of CEPAC. I'm the Director of Outreach Research and Cardiology at the National Hospital Heart Center. I'm an Assistant Professor at Harvard Medical School.
Hi, Reverend Al Whitaker. I'm the Regional Director for the Community Health Strategy for the American Diabetes Association.
I'm Chris Jones, a health economist and Network Director of Venture Investments for the University of Vermont Health Network.
And I'm Rob Asseltine, Professor and Chair of Division of Behavioral Sciences at the University of Connecticut Health Center. At the beginning of every CEPAC meeting, we want to ensure that none of our CEPAC panel members nor any of the speakers today have any undisclosed financial conflicts of interest with the healthcare industry. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy, but we do want to offer the opportunity for any panel members to update conflicts. See none. Our other speakers will be asked to do so as well. And now I'll introduce Dr. Dan Ollendorf.
Thanks, Rob, and good afternoon, everyone. Thank you for coming to the second half of our July 12th New England CEPAC meeting. So I'm going to introduce the topic, and I'm going to be mindful of the fact that while our research team has focused very intensely on this topic to try to understand all the nuances and spoken to many stakeholders, including patients and patient advocates, you're going to be hearing from a bunch of men about endometriosis, and so I apologize for that in advance. So we like to try to set context for these meetings by really kind of bringing it down to the why we're doing this. And so with any review, we hear both informally and formally from stakeholders about the topic at hand, about the considerations that we should be thinking about when we think about disease and its treatment. And so, there are a couple of considerations here that are really critically important to understand. We talk about unmet need, but here's a quote I want to read that we received in a comment from the Society for Women's Health Research. There's an important unmet need to treat patients with symptomatic endometriosis. With no cure or innovations for the past 2 decades, new diagnostic and therapeutic options have the potential to improve a woman's health status significantly and thus reduce the social and economic burdens associated with this disease, including medical expenses. And so focusing on the phrase, no innovations in the past 2 decades, that really defines what unmet need means. On the flip side, from a health system perspective, this is a quote from a Wall Street publication describing how prevalent the condition is. About 1 in 10 women suffer from endometriosis during their reproductive years. So an approval could generate annual sales well into the 9 figures. Elagolix's total market opportunity could be even bigger than that. AbbVie released positive data for the drug from the first of 2 uterine fibroid trials on February 21st, and on Tuesday it reported positive data from the second. So this really highlights the tension that this group is often dealing with, the potential for clinical innovation that will help patients, but the challenge of trying to figure out how best to afford to make that treatment available. So there are some general considerations as well. We're always here because increasing healthcare costs affect individuals and affect budgets. New mechanisms of action, new types of treatments often raise questions about who they're appropriate for, what are the appropriate patient populations, and how that cost, as I mentioned, can be managed. Patients, and we'll hear from patients today, can have difficulty accessing drugs. There are step therapy protocols often in place, requirements to switch drugs even if patients switch insurers, and increasingly so, high out-of-pocket expenses for patients and their families. And so the need for groups like this to come together is around an objective evaluation and a public discussion of the evidence on effectiveness and value. So to talk a little bit about how we develop our reports, and this report was no exception, we first start with a scoping phase that takes guidance from patient groups and patient advocates, clinical experts, some of whom are also here today, manufacturers, and other stakeholders. The ICER staff, along with its external collaborators, looks at the evidence very closely, and we also do economic evaluation to try to understand how the value aligns with the benefits. In this case, we worked with a team from the University of Colorado at Denver. We receive public comment, and we consider those comments very carefully in deciding to revise our documents. The two major public comment periods are around our draft scope and our draft report. And so we often make changes based not only on our internal considerations, but on the nature of those comments. And we had the benefit of having two expert report reviewers, Dr. John Petraza, Chief of the Division of Reproductive Medicine at Mass General Hospital, and Casey Berna, an endometriosis advocate who also joins us today. So just a little bit of background on how the evidence report is structured to support the CEPAC voting and the policy discussion. So our goal, the goal with any of our projects, is to produce evidence and information and have that discussion reflect how to best get to sustainable access for high-value care, to high-value care for all patients. And to do that, we really have two basic foundations. One we call long-term value for money, and the other focuses on the construct of short-term affordability. Long-term value for money, in turn, has several components to it. So there is that clear-eyed look at what the clinical evidence that's available to us is telling us and what it's not telling us. There is that evaluation to extrapolate that information over the long term in an incremental cost-effectiveness analysis. But then there are also elements that fall outside of both of those realms, other benefits that may not be well captured in the clinical evidence or easy to include in a model, and contextual considerations around the nature of the disease, the rate of innovation for that disease, et cetera, that also can play a role in certainly the panel's considerations around potential benefits of any new drug. But there's also a recognition that, particularly with a condition that is as prevalent as this one, health systems will struggle to afford to pay for high-priced care if there is not a clear determination of who the right patients are, when the best time is to treat them, and with what. So we do a budget impact analysis to try to inform that. That's not a consideration of value. It's actually a consideration of how the health system should, in many cases, best introduce a high-value treatment into the armamentarium. So I will cede the podium in a minute to our internal research experts and external research experts. But just to kind of review the agenda for you, we'll have a presentation of the clinical evidence and the economic modeling. First, the clinical evidence review will be presented by Dr. Steve Atlas, Director of Primary Care Research and Quality and the Quality Improvement Network at the Mass General Hospital. And Dr. Brett McQueen will present the cost-effectiveness analysis, professor at the University of Colorado, Denver. We'll then have time for public comments, both from the general public, actually just from the general public. I don't believe we have manufacturer comments today. The panel will take its votes on the comparative clinical effectiveness and the value of elagolix. We'll then have a policy roundtable discussion with our patient advocates and our clinical experts, as well as some other stakeholder representatives, payers, will come to the table too. We'll conclude with some reflections from the experts on the roundtable, as well as our New England CEPAC panel, and then hopefully be able to get you out of here right on time at about 5 p.m. Just to introduce who's sitting at the table to my left, Casey Berna, endometriosis and infertility patient advocate, as well as Heather Guidone, a patient advocate as well. Dr. Elizabeth McGee, who's here at the University of Vermont, and Dr. Rebecca Flicht from the Cleveland Clinic. So we're appreciative of your coming here to talk with us today and to share your expertise and guidance. And I want to let everyone know that the only reason that they're separated at two ends of the table is so that they can actually turn around and see the slides if they want to, not for any other reason other than that. So without further ado, let me turn the podium over to Dr. Steve Atlas.
Good afternoon. As in always, if there's questions that occur, feel free to interrupt me. I think last time you all were not bashful about doing that, but that's totally fine to do. I would also just like to acknowledge that really the tremendous amount of work done by the internal staff, Jerry Kramer, Patricia Sinat, who's here with us today, as well as Leslie Jiang, really were instrumental in what I'm talking about. And obviously, as mentioned, we don't have any relevant disclosures to report for this report. So just the topic and context, endometriosis is recognized as a chronic gynecological condition characterized by the attachment and proliferation of endometrial-like tissue outside of the uterus, typically in the pelvis. And that then is associated with the symptoms that women report, and these symptoms can vary greatly in severity. Obviously, for today, we're going to be focusing on women with more severe symptoms, but they broadly fall into the major categories of painful menstrual periods. The medical term for that is dysmenorrhea, non-menstrual pelvic pain, as well as pain during intercourse, and the medical term for that is dyspareunia. This is actually a relatively common condition, 6 to 10% of women of reproductive age, and the peak prevalence is in the mid-20s to the mid-30s, though it may actually be earlier because, as we'll talk about in a little bit, there's often a delay in diagnosis. And the estimated population is large, 4 to 10 million women, though that may diminish in relationship to what we're going to be talking about today in terms of those with moderate or severe symptoms. There are a range of therapies that are available for endometriosis, including both medical and surgical ones. We're going to focus today on the medical, but all of them have the commonality is that they are not offering long-term benefit or cure, which is something that is really obviously important to patients. The initial therapy is often given empirically before a definitive diagnosis is made, and that's often with non-specific treatments like non-steroidal anti-inflammatory drugs, as well as hormonal contraceptives in a variety of different forms. There are FDA-approved drugs. The most common for second line is the gonadotropin-releasing hormone agonists. These are only available as a most commonly injectable drug, but there's also an intranasal version. They're FDA approved for up to 6 months of therapy, though you can give, if they are beneficial, you can give an additional course for up to 1 year. They work by initially stimulating the pituitary to actually increase hormone release and actually worsening symptoms, but with ongoing release of the hormones, it then leads to a suppression and a shutting down of ovarian hormones, which is the way these medicines are thought to work. Elagolix is the drug that we're talking about today, and it's actually a short-acting medicine. It's an oral medicine as opposed to these injectable non-peptide, and it's a GnRH antagonist that's, as we'll talk about, is under FDA review. It's continuing to. And it works by rapidly reducing the pituitary ovarian hormones and producing a dose-dependent decrease in estrogen suppression. So it works, there isn't the surge, and it works quickly, and because it's a short-acting medicine, if you stop taking it, potentially the side effects go away, but also the benefit as well, and we'll come back to that. From the patient's perspective, these symptoms can be quite impairing, can affect quality of life in terms of increasing depression, reducing sexual satisfaction, and obviously disrupting personal relationships. We also heard that there's a misperception that endometriosis represents just bad menstrual cramps, and that has led to a sense that there's an underappreciation of its impact, and that impact affecting both work and family issues to a great extent. That misperception also may be viewed as going to the medical community, where there may be lack of sufficient awareness by clinicians that may in part account for some of the delay in diagnosis, as mentioned, as well as the perception that there's not enough research looking for new therapies for this condition. Some patients also commented upon that the focus on elagolix and medical treatment may also take away from interest in advances in surgical technique. But again, that's not the focus for this talk, but was something that we heard several times. So the scope was to evaluate the comparative clinical effectiveness of elagolix for symptomatic endometriosis, and the comparators here were primarily placebo or no treatment, the GnRH agonists that I mentioned, other hormonal contraceptives, as well as aromatase inhibitors, which we're not going to talk about a lot, but basically these are medicines used primarily to treat breast cancer, but they have also been shown in some small trials to have effect on endometriosis. The outcomes, as mentioned, that we're focused on dysmenorrhea, non-menstrual pelvic pain, their impact on quality of life, as well as the use of other medications such as analgesics, including opiates, to decrease symptoms. The harms are the harms associated with lowering estrogens, which think of it as a menopausal effect in terms of low estrogen in things like hot flashes, headaches, nausea, things like that, as well as more long-term effects in terms of bone loss, and specifically we'll talk about bone mineral density changes, as well as effects on lipid profile, cholesterol, and the potential harms associated in terms of cardiovascular disease. And then finally, we'll comment on that these being short-acting partial agonists, they don't fully shut down hormone production. Elagolix may be associated with pregnancy, and while infertility is a problem in this population, there's also a question about how safe elagolix would be if a woman got pregnant while taking it. So the body of evidence, as opposed to this morning's where there was a large number of trials, were actually many fewer trials. There was 5 key studies that we'll talk about for elagolix, 2 phase 3 randomized trials and 3 phase 2. 4 of the 5 trials included a placebo arm. 2 of the 5 will comment on there was an active control, one of them being a progesterone, a long-acting progesterone, dipomedroxyprogesterone acetate, and the second was the most common GnRH agonist used, which is Lupron or Luproline. There's a lot of differences among these trials. There was differences in dosing of the elagolix in the trial, which I'll talk about in a moment. There was also differences in how long patients had symptoms, varying from 1 year to 10 years of before initial diagnosis before entering the trials. There was also differences in patient factors such as weight that I'll comment on. There were major differences also in terms of the endpoints chosen, as well as the methods used to assess those endpoints. This is a complex trial slide, so I just want to focus. The first 2 rows are the phase 3 trials, and then the phase 2 trials are below that. The only commonality in terms of dosing for all 5 of these trials was that they each had a 150 milligram once-a-day dose. The 200 milligram BID dose that we're going to focus on, in which Brett will be talking mostly about in terms of the the cost-effectiveness modeling was only in the phase 3 trials, and that's something that's important to consider. And there was different dosing in some of the phase 2 trials. The other, in the third column, the patient characteristics, obviously the size of the phase 3 trials were considerably larger than the phase 2 trials. And then finally, in the final column, the outcomes assessed, the primary outcomes were quite different. So talking about switching to now what were those outcomes, the primary outcomes reported in the phase 3 trials was patient-reported clinical response. And it was a complex reporting that it included a statement of either improved or stable use of analgesics, as well as what they termed a clinically meaningful reduction in either, meaning there was two primary outcomes, dysmenorrhea, sort of menstrual pain, as well as non-menstrual pelvic pain. The way that they derived this clinically meaningful reduction is actually quite complex, and we may talk about it later in some questions. There were numerous secondary outcomes, including individual questions rated on a numeric rating scale, as well as this Bilberoglu and Berman scale, which is unique to endometriosis, which is a 4-point rating scale that we'll talk about. So when we talk about B and B, that's what we're talking about. Because the primary outcomes were separated for both dysmenorrhea and non-menstrual pelvic pain, as Brett is going to present, we took a combination to derive a weighted average so that we could come up with some general overall measure of benefit of these drugs. And Brett will talk more about that and how that was derived from the CA model. But that is not data that has been in published reports as of yet. And then finally, there's quality of life measures, and there's one endometriosis-specific measure, 30 items, 4-point response, covering 5 domains that was available for us to review. So with that as a background, let's look at the results. So this is sort of the key results slide from our perspective. So this is primary outcome from the phase 3 trials at the latest outcome assessment at 6 months. The first column is the dysmenorrhea, the menstrual pain, and then the non-menstrual pain. And then there's the two trials. They were both reported in the same publication in the New England Journal, but they were presented separately. And so they're presented separately here. And what you can see is that with increasing dose, there's a dose-response effect showing improving clinical response going from placebo from the 150 milligrams 3 times a day to the 200 milligrams twice a day for both trials. There are differences between the dysmenorrhea and the non-menstrual pelvic pain. The 2 points to mention are, number one, is that the placebo effect is larger that you'll see in terms of the non-menstrual pelvic pain, and the absolute benefit of the higher dose is also less. So the magnitude of the benefit is less. However, these are both statistically significant differences as reported in the trial. Okay? So other secondary outcomes in terms of pain also showed statistically significant improvements in dysmenorrhea and non-menstrual pelvic pain comparing elagolix to placebo, both for the numeric rating scale and this B and B scale. This weighted average that I mentioned briefly, sort of combining this clinical response for both dysmenorrhea and non-menstrual pelvic pain, we derived that the benefit here was 65.6% of women on the 200 milligram twice a day had that benefit versus 35% for the placebo group. And as mentioned, Brett will talk about how that was derived, and that will be the outcome benefit that we will be modeling. There were also differences between elagolix and active comparators in the phase 2 trials that were not significant. Some of them had small differences in favor. There were no statistically significant differences, and most of the differences actually were comparable, or in some cases, elagolix was less effective than Lupron. But again, those doses were lower than what was reported, than what was done in the phase 3 trials. In terms of quality of life, there were similar outcomes, that there were significant benefits on all dimensions of the EHP30 at both 3 and 6 months for the higher dose. There was less benefit, but for several dimensions, there was still benefit at the lower dose, the 150 milligrams. And there was a statistically significant difference here for quality of life that favored the Lupron versus the lower dose of the elagolix. And there was no differences in quality of life, or for that matter, pain outcomes between the progesterone, the injectable, the depomedroxyprogesterone, and the one phase 2 trial that included elagolix at 150 milligram once a day dose. So in terms of harms, this is again a complex slide showing a lot of things. Placebo, the lower dose elagolix in the second column, the higher dose, the Lupron, which, just to mention, many of those outcomes are actually not derived from the paper. They weren't reported. Some of these outcomes are actually reported from the FDA material that's published on that agent. And then the depomedroxyprogesterone. And the major point, so that the first row, any adverse event leading to discontinuation showed relatively low rates of discontinuation with this medicine in the phase 3 trial, slightly higher, but these were not statistically different between the different doses of the medicines. In terms of the specific side effects, again, most of the side effects that were common and reported related to effects of estrogen depletion. Again, sort of what one would expect from a menopausal state: amenorrhea, headaches, hot flashes, insomnia, mood swings increased with increasing dose. Not mentioned here, but the rates of amenorrhea continued to increase. And so in longer-term follow-up studies that have actually recently been released, actually even since we did the report, the rates of amenorrhea on the higher dose can actually be as high as 60%. And that may be some things that we'll comment on later. In terms of other harms, as mentioned, these effects loss of estrogen can lead to bone loss, and that was seen in these trials. So there was a dose-dependent reduction in bone mineral density at the standard places that it's measured, the spine and the hip, the femoral neck. And the degree of loss of 12 to 13% in the 200 milligram group, having more than 8% after 12 months, as a comparable. With menopause, the reported rate of loss is 1 to 2% per year, and with drugs such as prednisone, steroids, which are commonly thought of as the risk being bone loss, that's on the order of 10 to 20% per year. So this amount of bone loss would be considered to be sort of comparable with drugs that are associated and where clinically we're concerned about bone loss. The other thing to mention is, up to the data that we have, even with discontinuation, while the bone loss diminishes over time after coming off of it, it did not, at least in the studies that we've seen so far, go back to baseline. In terms, the same type of effect was seen with cholesterol, so that there was associated increases in total cholesterol, bad cholesterol, the LDL cholesterol, as well as fats or triglycerides that may be that obviously are associated with heart disease, and so we consider that in our modeling. As mentioned, the safety of elagolix in pregnancy is uncertain, and because amenorrhea is not induced in all women, that is a concern that is still unclear. And then finally, the FDA in March, as Dan mentioned, held the release of their opinion for this drug based on liver function tests. And there's actually, in our careful review, there's actually really no mention of liver function test abnormalities in any of the publications or appendices that we could find. In terms of controversy and uncertainties, as mentioned, there's differences in dosing, duration, endpoints, outcome analysis between the phase 2 and phase 3 trials. The direct comparators, elagolix, to active comparisons from the phase 2 trials were limited by many factors: small sample size, incomplete reporting, imbalances in some baseline characteristics, a short duration of follow-up, high attrition, and limited statistical testing. All of this led to us being unable to perform quantitative indirect comparisons among these different regimens. And then finally, importantly, is that these trials of both benefit and harm had only comparative data for 3 to 6 months, and yet we're considering these medicines as for a chronic condition. And again, the potential risk of long-term, even after stopping, such as with the bone mineral density, also adds to some uncertainty about their long-term effects. So in terms of our rating recommendations for elagolix versus placebo, we viewed it as promising but inconclusive, primarily based on issues around safety, as well as the uncertainty of the FDA concerns that are not reflected in the published data. Elagolix compared to the active comparators, GnRH agonists, hormonal contraceptives, and also aromatase inhibitors. I don't focus on aromatase inhibitors because there's actually no published randomized data for this. And so for all three of these, we rated, compared to active comparators, that there was insufficient data. Okay? And then finally, potential other benefits, contextual considerations. We recognize that elagolix is really the first new treatment in well over a decade for this chronic condition. That the oral formulation may actually have real benefit from patients' perspective over the injectable or intranasal versions. It has more rapid reversal, so if there are side effects, it gets out of you quicker. And it also avoids that surge that's associated with the GnRH agonist, though you could also raise issues of if you stop taking it, the benefits may wane quicker, as well as there may be issues with compliance with a twice-a-day medicine in terms of versus these injectable medicines where you get the shot and you got it for 3 months. These medicines also, even though it's a new medicine, it still works in the same method, the same underlying pathophysiology of reducing hormone levels, and it isn't the cure that many patients and patient advocate groups are looking for. And even if it's helpful, again, this is a chronic condition. If the FDA approves it for 6 months and a woman benefits from it, what are they going to then do? So with that, I'll turn it over to Brett McQueen, who will present the cost-effectiveness modeling. Are there any questions maybe before?
Any questions for Dr. Adams?
I was nervous because Rebecca did gave you all the summary, and she did it so well. But you did a great job. In no small measure to listening to you.
So I just actually have one quick question. I know we've talked about this as a team in terms of uncertainty, but from my recollection, one of the entry criteria for the phase 3 trials was response to prior therapy among the women entered into the trial. So it makes even the placebo comparison somewhat challenging to think about if the clinical consideration had been use of elagolix after failure of those prior therapies. And I'm just wondering if you want to comment on that.
Yeah, so as in any phase 3 FDA trial, it's not what we do in usual practice. So these women had been diagnosed up to 10 years before requiring a surgical diagnosis, which is sort of the definitive. They could have been on prior therapy, but they actually had to stop any therapy that they were on for a washout period. During that washout period, they had to be maintained on basically non-steroidal agents, before they would then be randomized. So if that's what you're getting at, this is not sort of immediately going from this is the phase 3 randomized trial. It's not necessarily what clinicians would do as part of routine practice.
If any of the clinical experts or patient advocates have comments to raise at this point, feel free to do so. One thing we'd ask is, since we haven't made any disclosures yet, if you could start off with those before saying something.
Elizabeth McGee, University of Vermont. I would like to disclose that I am our site is under consideration for one of the current ongoing trials for elagolix. We have not signed any contracts with them, and I don't believe I have any proprietary information in my head at this point. I don't think they've told me anything that's not public knowledge. But we haven't signed any contracts. I have not received any money from AbbVie at this point, but would like to disclose that we're under consideration as a site. One of the questions that I had, and we were kind of talking here, is dyspareunia and sexual dysfunction as an issue, because that's one of the biggest issues with lupron, where you have suppression of the estrogen levels, and hypoestrogenemia does result in vaginal changes that can cause dyspareunia. And so I didn't really see that addressed in these issues. And this is something that, say, birth control pills don't do necessarily. And so the atrophic vaginitis that can occur with pituitary suppression and hypoestrogenemia is a significant quality of life issue. And then the other thing that we noted was the amenorrhea was listed as a bad thing. Actually, that's a goal of therapy. If you don't have periods, then they don't hurt.
Yeah, we were kind of chatting together. So Rebecca Flake from Cleveland Clinic. That was such a nice summary. But I don't have a question. I do have a comment, and this would be for people who don't kind of live and breathe endometriosis the way that we do. But I think one of the major criticisms of this study, which is the phase 3 trial in the journal, is kind of, as you mentioned, some of the selection criteria for the groups that were studied. And the diagnosis of endometriosis in these patients was made at some point in the last 10 years by surgery. And all endometriosis is not necessarily created equal. There's a huge range of clinical presentations and clinical signs and symptoms. And so there's not a lot of information available here about their stage of endometriosis, their clinical course, what kinds of therapies they may have responded to. And as you can see in the results, the placebo effect is pretty considerable as one of their comparisons. So just a couple of points in interpreting the findings of this particular publication. I think in our circles, one of the major criticisms is sort of the lack of information about the patients they were actually treating for the clinical trial, and like what degree of endometriosis they actually had.
Those are great points. Just to comment, in the full report, we do comment, we do present the data on dyspareunia. And just to summarize it briefly, there was benefit associated with elagolix in a dose-dependent fashion. So the diminishing symptoms may be offset by, there was still benefit associated with it. In the trials the phase 2 trials comparing, for instance, Lupron to elagolix, there wasn't sufficient data to be able to compare some of these secondary outcomes like dyspareunia. So it's hard to so it's very difficult to say whether elagolix would be better or not for that specific issue.
And I think that point kind of follows the theme that is in this paper, which is at the 150 dose, you don't necessarily see those benefits. If you really want to see a benefit in dyspareunia or any of those other outcomes, the max benefit is with the higher dose.
Correct. And as Brett's going to talk, that's the focus for his cost-effectiveness analysis. So I'll turn it over. Oh, yes, Jason.
Just a quick follow-up question to that. I guess when you advise us, setting the assumptions about the two phase 3 trials in the journal paper, would you advise us to either just be uncertain about the extrapolated validity of those results, or would you say that, I had the sense from your comments that in your field, you all think that these patients may actually have less severe disease. So could it be that this trial actually underestimated the efficacy of the drug? Or is it more that we just don't know?
I mean, I think you could make the argument that this is more of a real-world example. We're throwing in a bunch of patients with various stages of disease. Say the last part again.
So, I mean, it just in general, randomized controlled trials, in general, we try to understand the implications of that for real-world practice. There's like an external validity issue. So often, I'm making generalizations here, but I think that in many randomized controlled trials, because of the extremely rigorous inclusion criteria, the efficacy can be exaggerated.
Yeah.
It almost feels like this could be the opposite situation. Because of all this heterogeneity, because of relatively not that severe disease, that we could is it fair for us to even entertain the opposite assumption that the efficacy is actually greater than the safety?
It's possible. I think unfortunately so little is known about these patients, and they have such a wide period where they could have been diagnosed. I think truthfully a better design study would have had a more immediate diagnosis of endometriosis to try to parse that out, because endometriosis and chronic pelvic pain are so difficult to untangle from one another. So I think there may have been patients here. I know in the inclusion criteria they say that these were not patients who had non-endometriosis pelvic pain, but I don't know how they can necessarily say that.
Jason, just specific, patients during the washout phase, one of the reasons to do that was that they had to have a certain level of symptoms to then be randomized. So there was some effort to identify symptomatic patients, though you're correct, it's very difficult to say how do those compare to the patients that may be seen in clinical practice by specialists. I don't think there's any way to easily say that.
I'd like to comment a little bit further to your question, Jason. I think you could also make the other error in, because mild patients were also included, you might overestimate efficacy. Because basically most of us use continuous birth control pills where patients don't get periods as our first-line treatment of endometriosis, even before surgery. And so if you're including patients that would be effectively treated by continuous oral contraceptives, then if it helps that's great, but is that really helping this difficult group of patients that don't have easy treatment?
Those explanations are helpful. Thank you all.
I think this relates to a bit about what we were saying, in that when you approach a patient with endometriosis of various severities, do you really have in your mind a step therapy approach where you would say, let's say, Upfront for a later step? And when we look at the studies we're looking at right now, we're not really dividing up who's failed step therapy as opposed to just what the effectiveness of the medication is. And that doesn't seem to be necessarily, to me, it doesn't treat this disease the way you would approach this.
I think that's a great point, and that kind of gets to what Dr. McGee was saying. And all of the professional societies in OBGYN, whether it's the AICRM, ACOG, any of the European societies, advocate a stepwise approach with first-line and second-line agents. And it's fine to start a first-line agent before surgical diagnosis. At a certain point before you go to some of the second-line agents, you're going to want to actually get tissue diagnosis to confirm in most cases.
On the harms, since we spent some time talking about this in the report on the bone mineral density, I mean, we assume that you lose bone mineral density and you're having increased risk of fracture. But was there any information on fracture risk? I know that the study probably didn't go out far enough to look at it, but
Right.
it takes a while for the bone mineral density to recover after stopping treatment. Did they say how long they followed patients to see after discontinuation, how long what that time frame was?
That's a great question. So obviously these are young premenopausal women. There's no fractures that were at least reported during the time frame, but obviously these are women who are going to live a long time, and starting early with bone loss, most would consider to be a very concerning thing, or at least potentially concerning. So And then the second question, as I mentioned, there's only 6 months of data after stopping the medicine, so it is possible that things could return to baseline if given enough time. The publications where they talk about bone loss are an abstract, and they kind of like say, oh, it goes away. And that's a bit of it does diminish, but we wanted to emphasize to you all that it has not yet returned to baseline. And until, from a long-term risk, if it never did, that would be a potentially important long-term risk for a young woman. So with that, thank you all. And we'll obviously come back to more of these issues.
Thanks, Steve. Is this, mind if I use this instead? Yeah, good. That's actually a great transition into cost effectiveness, because we're actually modeling part of that, fractures over time. So you'll see a little bit of that. So my name's Brett McQueen. I'm an assistant professor at the University of Colorado. Let's see, does this thing move over? Or do I have to use there we go. I just want to acknowledge our team members from Colorado, Mel Whittington, John Campbell, Sam McGuffin, and then, of course, all of our ICER colleagues. Is this not? Oh. Should I click on the wrong one?
Yeah.
That's on. Yeah. You have to turn it on. Yeah. Okay. And then Varun Kumar, in particular, was really helpful for this. But, again, the whole ICER team was really helpful with this, and Rick Chapman as well. We have no conflicts to disclose related to this research. So our objective for this was to estimate the cost effectiveness of elagolix for the treatment of endometriosis-associated pain in adult premenopausal women. And that base case population is, so Steve Atlas outlined all the different trials. There were multiple, but our focus for the model is EM1 and EM2, those phase 3 trials that we saw. And that starting age is 32, and that 5.5 gets to that baseline score on the numeric pain rating scale. So that's that moderate to severe pain, tilted slightly towards dysmenorrhea. Obviously, the conversation we just had is indicative of that. We also, part of our previous conversation was using elagolix at the 200 milligram twice daily dose instead of the 150 once a day, or instead of some of the other doses within the phase 2 trials. Reason being, it offered the most efficacy in terms of pain reduction and stable use of analgesics. We have no active treatment as our comparator, and that's for a couple of different reasons. One, lack of comparative evidence in the literature, across the whole literature base. Two, we also had trouble translating the small sample phase 2 trials that didn't have a lot of carryover into the phase 3. Some of the response definitions were different, so it was hard to use, say, a GnRH agonist as a direct comparator here. So that's the reason for that, for no active treatment. Our model is a decision tree and then a Markov model. What that means is, up front, we do this short-run model where we're just looking at all of the costs and outcomes from the within-trial results, within EM1 and EM2. Then we take that information and we extrapolate to the long run over 18 years. Why 18 years? That's about at the average age of menopause, or the age 50. And so that really has to do with the biology, as Steve talked about with endometriosis, as well as the mechanism of action of elagolix. Our cycle length of 3 months represents the lowest denomination of response. So that's the trial had 3-month and 6-month response rates, but you'll see in a little bit that we actually modeled downstream surgeries. And among surgery interventions, 3 months was that also the lowest denomination for response. So there's a couple different reasons why we use that cycle length of 3 months. Primary outcomes, cost per quality adjusted life year gained. And then the secondary outcomes includes a variety of benefits and risks. We focused on surgeries, which you'll see there's a benefit in terms of reduced surgeries modeled over time. And then the risks that we focused on were cardiovascular disease, given the changes in lipid panel levels, and then fractures. And I'll get into a little bit. It was difficult to model this because it was under the age of 50. A lot of these events don't show up until later in life. So you'll kind of see that some of these events are quite rare. So this is the model schematic that I just talked about. On the left-hand side, which I'd like you to focus on now, we've got the 0 to 6 month assessment of response. We've got forgive me for standing behind you, by the way. We have elagolix and then the comparator here. women were bucketed from the trial into response, which was characterized by a clinically significant reduction in pain, as well as stable use of rescue analgesics, or no response, discontinuation due to surgery, and adverse events. So from there, for example, if women respond, after the 6-month time horizon, they transition into this M1 state, which is characterized by quality of life that's similar to their peers, women of their same age in the United States with no chronic conditions, okay? And then if they discontinue or they do not respond, they can move to moderate to severe pain, which is characterized by lower quality of life, increased use of pain agents, as well as other resource utilization like outpatient visits. And then from there, they can choose a surgery such as a conservative laparoscopic surgery or a hysterectomy, which can also be conducted laparoscopically, but it's more of a final state in this model. These bottom states here really reflect success or non-success from surgery. I'd say the biggest key assumption here that we're making is we're taking the short-run decision tree results of the phase 3, we're projecting that into the future without really knowing whether the benefits are going to persist in terms of pain reduction, whether the risks, we just had this conversation, whether after you discontinue, do those persist over time? Do they get worse on treatment? So those are some of the issues that we're really going to run into and that could lead us to, or that was a factor in leading us to the evidence rating of promising but inconclusive. Another thing to note here, the acquisition price is assumed based on a market research firm. So we just talked about it's not FDA approved yet. The price we're using is a projected price in the base case. But as I noted previously to the panel, that we're really going to talk about whether this price is within a range of value-based thresholds. Okay, so the key parameter in this model is the upfront response because it determines who gets into the model, who stays on the treatment, and then who moves downstream for surgeries, et cetera. So in the trial, we had the outcomes were split by dysmenorrhea and non-menstrual pelvic pain. So in the initial model and the draft report, if you noticed, we actually had cost-effectiveness estimates by dysmenorrhea and by non-menstrual pelvic pain. Everyone was very upset at us, so we did revise and did a weighted average combined response. So the idea behind this weighted average combined response is that within a time of menstruation of any given model cycle, or about 5 out of 28 days, we're assigning this 76% to that duration of time. The remainder of the time gets assigned that 62.1%. That's why this 64 is pulled down towards 62%. The vast majority of time is obviously spent in a non-menstruation state. So this parameter here is used for our base case. Steve also presented this estimate. That's that proportion that ends up in the reduced pain state for both treatment arms. The other very, very key parameter here, beyond just the absolute value, is also the absolute difference. So if you see this spread wider, and you'll see, I'll give you a couple of examples, it gets bigger beyond 29%, cost-effectiveness estimates are going to go down for elagolix versus the comparator. Some other key parameters, pain recurrence, which we use as discontinuation due to lack of efficacy. Again, this is one of those parameters that we take from the trial, we project into the future. Discontinuation due to adverse events and surgeries, and then we also included adverse events. If you want to see any of these values, please look at the supplemental slides. They'll be in there for you. Some of the other key parameters include the health utilities, and to do that we have to calculate, to calculate quality adjusted life years, we need these health utility values. And the reduced pain health state, this is really representative of women that responded either to elagolix or the comparator. This is their quality of life after they've responded on treatment, their reduced pain, and it's about the same as a woman of the same age of their peers in the United States with no chronic conditions. Then you see this big deduction, right, for this moderate to severe pain health state. That's a big difference. That is directly mapped from that numeric pain rating scale of 5.5, suggesting these women, on average, are in pretty significant pain based on that difference between the reduced health pain state and the moderate to severe pain state. So as that widens, this is going to be another significant parameter that as that difference gets bigger, the cost effectiveness results can change. So let's see how this all then affects the results. Well, I talked a little bit about our secondary outcomes, which are sort of clinical in nature, meaning surgeries, avoided surgeries, which could be a benefit in terms of elagolix versus the comparator, and then some of the risks. So first, we've got quite a few surgeries in the absolute value in terms of elagolix and comparator, and then a pretty significant reduction in laparoscopic therapeutic, as well as in hysterectomy, which obviously can also be conducted as laparoscopic. So you see that we have a pretty significant reduction, and that benefit comes at a slight or modest increase in cardiovascular disease and fractures. Now, again, this is going to go back to that caveat that there are already rare events per 1,000 people for cardiovascular cases for women less than 50. So these are already rare. For fractures, in particular, the best risk estimates we got from this for this model actually started at age 40. So we're only modeling 40 to 50. And above 40, among all age groups above 40, 40 to 50 had the rarest risk in terms of events of fractures. So that has to be taken into consideration that, again, as we move forward, and if bone mineral density changes greater than what we're seeing in the trial, these numbers may increase or may be different than what we're modeling. Okay, so our base case discounted costs and outcomes are split in the top two rows by the 6 months. So this is our within trial result. The bottom is over 18 years. That's the projection that we're going out past the 6 months. Intervention costs are a function of elagolix plus the use of NSAID and opioid pain management medication versus usual care, which is NSAID and opioid pain management medication alone. So that's why those costs are not zero. There's still a positive cost. This is usual care and no other active treatment. Non-intervention costs include surgical costs, outpatient visits, long-run adverse event management costs in the 18-year time horizon. So you're seeing elagolix come at a higher cost in both 6 months and 18-year time horizon, but also that increased effectiveness. And let's see how that then translates to the incremental results. So over the short run, we see this increase in cost, small increase in quality-adjusted life years, for an ICER of 121,000 per quality-adjusted life year. Over the long run, there's a bigger cost because we're following women for a longer time. They're paying for the treatment over longer time periods, but then they're also incurring this higher benefit for ICER of 77,000 per quality-adjusted life year. So why the difference between the short run and the long run, right? Why the difference? Well, the key here is that, again, we're taking the short run. We're assuming very low discontinuation rates over that 6-month period. Very few women discontinued. Steve Atlas spoke to that a little bit. We're also assuming the benefits, the quality of life benefits, persist over this entire time of 18 years. So really, what we're saying here is that only women that respond to the treatment within that 6 months, that if I'm a physician and I'm I'm prescribing elagolix to a woman within that 6 months, I have to be confident that I've identified a responder versus a non-responder. And then I'm only giving that responder the treatment cost as well as the treatment benefit over that 18 years. So this discrepancy right here between these two is really what led us to, or a factor in what led us to that evidence rating of promising but inconclusive. Meaning we don't have any long-run discontinuation rates, we don't have any long-run quality of life benefit estimates that we can really rely on over longer than a 6-month time period. In terms of our one-way sensitivity analyses, while this is a very tight range in terms of the variation, I just want you to pay attention to these estimates, which I talked about in the key assumptions and some of the upfront input parameters. Pain recurrence, which is our discontinuation due to lack of efficacy, and our endometriosis pain score, those two, if those are different over the long run, some of these results could be significantly different than what we presented or than what I just presented in the previous slide. We also varied all of our inputs and ran a simulation to see the proportion that were cost effective. And you see that we're in the range of 94 to 99% at 100,000 to 150,000. Okay, so I talked a lot about that response definition. So in our previous report, we created estimates for dysmenorrhea only and non-menstrual pelvic pain. And in the base case, I showed you this combined weighted average estimate. And really what that represents is that any given day on elagolix, a woman could respond. So the base case is based on any given day, whether it be during menstruation, outside of menstruation, any given day. For dysmenorrhea only, this incremental cost is higher because the response rate is higher. It's 76%. More women are on treatment, but they're also getting more of the benefit for an ICER of 55,000 per quality adjusted life year. In terms of non-menstrual pelvic pain only, if you recall, that response was much lower, 62%. So that's why this cost is lower and the benefit is lower for an ICER higher than the base case of about 86,000 per quality adjusted life year. Then we got actually requested data directly from AbbVie and found that they calculated an estimate for us, which is response to dysmenorrhea and non-menstrual pelvic pain, both. So this is response every single day to elagolix. That's what that represents. Versus the base case where we were talking about any given day, sort of an average estimate, right, for an average woman. This is assuming a woman will respond every single day. It's a very strict definition of response. That's why the proportion of those women are much lower. That we're assuming then it's actually not 76, it's not 62, it's more like 56% of women that were responding every day, which is why that cost is lower, and then the benefit is sort of in between these two, because they're responding every single day, right? So that for the responders, it's very beneficial. And that ICER comes out to be about 55,000 per quality adjusted life year. We also performed a modified societal perspective where we included lost productivity. Oh, yeah. Because in this piece here, yeah, because the proportion is lower than both of these in this case. Yeah. Well, so they're all getting the same treatment, but the response is different. So they're being, when they actually get into the Markov model, there's a different incremental response and absolute response. And then in the case of the lost productivity costs, because we're including both absenteeism and presenteeism, this drops the incremental costs versus the comparator because evidence suggests women with endometriosis have a significant amount of lost productivity, and elagolix is contributing to getting women back to work and getting women back, I should say, more productive at work for an ICER of approximately 45,000 per quality adjusted life year. So these are the threshold prices that I talked about at the beginning here, where we have both the short run and the long run. If you recall, the assumed price is about $7,000 per year, which comes out to be about $9.70 a pill. And so we're seeing that $7,000 annually between 50, 100, and 150,000. We're seeing that 7,000 fall within both of those ranges. In terms of our limitations, certainly the biggest one here, as I've noted already in the key assumptions, is the lack of long-run clinical evidence. Really key is discontinuation over time, the benefits of the pain reduction, and then any of those long-term risks that might be different than what we see past the 6 months. I also want to note that we did our best to calculate a weighted average of response. That's why we showed the response scenario definitions, just to give you an idea of how response impacts the model. And so in clinical practice, response is going to be key, just like it was with the agonists in the previous generation of treatments for endometriosis. So that's another key point. So in conclusion, with the available evidence that we have on EM1 and EM2 in the phase 3 trials, the estimated cost effectiveness of that 200 milligram twice daily dose falls within the range of 50 to 150,000 per quality adjusted life year by providing marginal increases in quality adjusted survival, and then some sort of cost offsets as well in terms of outpatient visits and other surgical procedures. In our public comments, we received, obviously, this was the big one, the model. I think everyone commented that they wanted one sort of estimate with response combined, so we did address that. In our original draft report, we only included absenteeism, but there was evidence on presenteeism, so we also included that in our lost productivity estimates. And then add-on treatment. So in the draft report, after a surgical procedure was performed, it's very common for women to go on an add-back therapy, like a GnRH agonist, combined oral contraception. We've done that, the price of that as well in the updated report. And then the maximum duration of elagolix should be considered. This was a comment that suggested the FDA label indication might be shorter than we're modeling this 18-year time horizon. But this, I think we address this by doing the short run within trial results, and then also providing that sort of clinical practice view of, if it's working, we're going to keep women on this treatment, because why would we discontinue something if it's working for them and the risks are manageable? So I think we address that with those two scenarios. So I think that's all I have. If you guys have questions, I'll take those now.
I think this is aimed at our clinical people as well. But what about the preservation of fertility over time? In terms of, is there any difference between the different treatments about how women are going to be able to maintain their ability to get pregnant with this condition over time?
So the role of endometriosis in fertility and subfertility is very complex. And there is a role of just having endometriosis that confers some amount of infertility or subfertility. Humans aren't infertile, they're subfertile, if you think about it. And so it does confer a lower fertility, lower compatibility. But endometriosis that is severe, stage 4, stage 3 and 4 endometriosis, where you have damage to the ovaries, damage to the fallopian tubes, that also has a bearing. But also surgery can damage your fertility. If you have pelvic adhesive disease because you had 5 surgeries that were non-curative, you had iatrogenic scar tissue that can damage your tubes. So the causes of infertility and endometriosis are multifactorial. Also the endometrium of women with endometriosis, because they may be immunologically or metabolically different than women without endometriosis in some way. They have a lower implantation rate for embryos. So you can't really have a white and black or yes and no answer to the fertility question about it. But I think you can talk about, does Upfront, does a GnRH antagonist have a role, have an effect on the primordial follicle pool, the total number of follicles or eggs in the ovary at any given time? And so does it kill eggs? Or, does it preserve them? And I don't think we really know. There's a lot of different data on Lupron. There was some early data on some of the early antagonists in rats and mice that showed that there might be a decrease in the primordial follicle pool, but that hasn't really played out over time. Those were like 20 years ago. So I think that question is, I would say, probably not, but we don't know for sure.
Great. And just to add to that, I think in clinical practice, what we see are women at a crossroads. They have endometriosis and they have to decide to either go on hormonal therapy to manage their pain or pursue surgery to manage their pain, or they have to focus on getting pregnant, and that will involve, fertility treatments up to and including in vitro. And so then they're living in pain, but they're trying to get pregnant, or they're treating their pain, but they're unable to get pregnant because of those treatments. And my guess is that elagolix would fall in that category.
Yeah.
Just one quick in the full report, but not presenting, the simple answer is there's no evidence in any trial data that any medication that we have for endometriosis has either a positive or negative effect on fertility, I think is the general. So we don't think that this has any benefit or harm, though there's a great deal of uncertainty.
In the model, just to follow up on that point, in the model we actually assumed a constant proportion that were off treatment for attempted and successful pregnancies. That was really the only way that we could get at the fertility issue based on the trial data. So that actually came directly from the phase 3 trial. Chris?
Can I make a couple points about
Yeah.
the model? I thought it was very nice. But I have two concerns about some of the assumptions that it was built on. The first is, for general practice in medicine is that we use medical treatments first, and if that fails, then we move on to surgery. And this might be where some of our patient advocacy groups want to weigh in. advanced endometriosis, and again, remembering there's a wide range of clinical presentations. You might have one little spot, or you might, as Dr. McGee mentioned, have your bowels tangled in with your ovaries, which are the size of grapefruits about to burst. I mean, we've taken endometriosis out of people's livers, out of the aorta, out of the brain. I mean, endometriosis can be worse than cancer. So there's a subgroup of advanced endometriosis where actually I would challenge that model of medical treatment before surgery. Those women, you're not going to elagolix their endometriosis away. Like, you have to go in and actually excise that endometriosis. And there are some specialists that focus on expert excision, which will hopefully reduce the risk of fertility, compromising indications, and other problems. But I see in your model that it's medical treatment first and then surgery if that fails. But there are probably many cases of the advanced disease which will actually require surgery first and then long-time suppression. And that might be a birth control pill, that might be elagolix, that might be Lupron. So that's just one thought in regard to your model. And then the other thing that I had a concern about is that it's sort of built on the assumption that it will continue working as well as it did in the first 3 to 6 months, but over 18 years. And I think when you look at the endometriosis data, one of the chief threats to treating endometriosis with things that initially work is that placebo effect goes away and that the benefits of treatment seem to go away, even highly effective agents, birth control pills. So as many as 50% will have a significant recurrence of their symptoms within 5 years after surgery or after birth control or after whatever it is that you choose. So it's a disease that has a very high recurrence risk.
Yeah.
And I'm not sure the model fully
Yeah, and I think to address that point, that was exactly why I labeled that as an assumption and a limitation, that ideally what we'd have in the model is a discontinuation rate that follows. It's a distribution over time. We just don't have that data on any of the old treatments either. We just didn't have that. Everything seemed to stop at 3 to 6 months. So it's just a challenge for us. Do you make that up and just assume something, or do you take what you have with the evidence? And for us, I'd feel more comfortable using what we have now, full well addressing the fact that in that sensitivity analysis you saw, that was one of the biggest parameters. So if that changes over time, that cost effectiveness estimate's going to go up. So.
One more thing, because I find this also interesting. You use the 200 twice a day dose, but I guarantee you that those women in the New England Journal trial knew that they were not getting a placebo. Like at that dose, the side effects are significant, and I'm sure that they were aware that they were receiving active treatment.
Yeah.
So I just want to make sure as people think about that data, you take that into account.
I'm a patient. I have no conflicts of interest to disclose. I also have severe endometriosis, and as a social worker in the community, I work with a lot of patients who struggle with infertility and who also have severe endometriosis. I think it's important in terms of fertility to recognize that the disease is tissue throughout the body that doesn't belong, and the body has an inflammatory response to this tissue, which causes pain and adhesions. The medicines, whether they be hormonal contraceptives, NSAIDs, or elagolix, doesn't actually treat the disease. It doesn't shrink the disease, so it's almost palliative in its effect, so that it doesn't really get rid of the disease. So patients, when they go off the medicine, will still have the disease, and the disease does cause infertility. So a lot of patients do have, especially with severe disease, myself included, have had great benefits going to an expert surgeon who does excision, which is really taking the disease from the roots and removing the source of inflammation. And this way the body can heal, and you're actually kind of like removing the source. It's been compared to benign cancer. I don't know if I actually, there's discussion whether that's an appropriate comparison. But none of these medicines actually remove the disease. So in terms of treating, as a patient advocate, what we recommend is that patients, obviously first-line treatment, and I'll talk about this more in my public comments, birth control, there's not a lot of huge side effects to birth control. We all know the side effects. It's been well studied. So going to, after, say, first line doesn't work, going to an excision surgeon who can, get rid of the source of the inflammation, excise the disease, as well as give patients more multidisciplinary tools that can help that don't have severe side effects are very beneficial. And I see and work with patients who have had these treatments who do very well fertility-wise. And obviously fertility preservation, having access to egg freezing and benefits such as that are also very helpful.
Heather Godone from the Center for Endometriosis Care. I have no disclosures. We keep talking about surgery, surgery, surgery. What we're not understanding, as much as Casey had said, is there are two different types of surgery. We're not talking about typical laparoscopy that is performed in any OBGYN office where they go in and they use the laser to zap a few lesions, send the patient off on their way, suppress them with medication, be it generate analogs or contraceptives or other, versus excisional surgery, which, as Casey has said, takes the disease out by the root. That is usually typically followed by multidisciplinary adjuncts such as pelvic floor therapy and other measures that would help with a multidisciplinary big picture approach. Specific to fertility, there's never been a pill or shot or any kind of medical suppression that improves or preserves fertility. On the other hand, in our stage 3 and 4 cases in our own center, and I know other centers have similar rates, we find very successful pregnancies after the disease is removed. There is no pill or injection that is going to remove adhesions that were created by the disease itself, and yes, as Dr. Flick said, prior surgeries. There is no pill, there is no injection that is going to restore normal pelvic anatomy. So we need to be very careful when we're conflating surgery versus surgery. We're talking about the correct surgery. And I think Dr. Robbins perhaps could speak more to that.
I don't know if you take comments from the audience or not.
Well, let's just hold off 1 second. We're going to move to public comments, Dr. Robbins, and then we'll invite you. I think, Chris, did you have just one clarification on the cost effectiveness?
So just coming back to the cost effectiveness model, and I think it's very good, so I wanted to highlight that. I studied this area for not specifically endometriosis, but infertility for 7 years as my dissertation. And endometriosis, whether it's the ICER or the HFPA, has always been noted as a cause of infertility. So I was just wondering, coming back to the trials, was a patient having or currently underway with infertility procedures and so on an exclusion criteria? Or were they matched for having had children previously? I'm just kind of curious.
Yeah, the trial baseline, the exclusion criteria and inclusion criteria, I think were 3 pages long. So I don't know if I can answer that offhand, but
participants were required to be using some form of non-hormonal birth control.
Yeah.
Now, obviously, age got pregnant in the elagolix term, so not everybody was.
As you would expect in an FDA trial, that they were supposed to be using 2 forms of contraception. That said, there were, I think 5 to 7 pregnancies. Most of them were on either placebo or the 150 milligram dose. And what you could imagine that as being is that beneficial, but obviously from an FDA perspective, that's an unknown substance in terms of its effect on pregnancy. And so they made comment that there was no significant birth defects noted. There were some minor ones. There was also a loss of follow-up for many of the pregnancies. So is it good, is it bad? There isn't information about pregnancy, and so the 150 milligram dose, you could argue you should be cautious about it.
So to come back to Dr. Wassky's comments, there could be an underestimate of the benefit in terms of overall quality of life, because of patients who might have received the benefit in terms of infertility or some fertility, in terms of restorative fertility, would not have had that insights as to those benefits because they were on birth.
Yeah, and your comment is very valid, and we got that up front in the scoping phase. And without evidence, that was really difficult to model. So, I think it's a great point, to point it out. There was no way to really model that specifically, but yeah, we did hear that early on, and I did my best to try to incorporate that. So.
Great, Dan. Just one more comment.
Just one quick response to, I think, one of the points that Dr. Flick raised. And so the challenge I think that Brett had was something you noted earlier, which is that we have this wide range of severity and stage, not a lot of information about it, no real clear subgrouping of treatment effects according to those parameters. So it's difficult to try to tease out, I guess, a more appropriate quote-unquote population for elagolix. And so that is just a challenge.
Yeah.
I was wondering if the cost of the DEXA scans or monitoring possible bone loss was included in your cost model.
That's a good question. We included a fracture management cost, which I would assume would include, it wasn't specific, but we tried to identify all sort of resources used for the fracture treatment and management costs. So but it was not explicit.
That's not screening.
Sure,
so
sure.
you would have an increased cost of the need to DEXA screen that you
Sure.
would otherwise have.
Okay, go ahead. One more, and then we have to move to culture.
I'll be in brief response. The Markov model, incorporating fracture, I don't see that as a health state here. Would they transition to that health state?
It's a good question. Yeah, it's actually an event-based calculation that's outside of the Markov trace or outside of the model figure that I showed. So it's only calculated outside for those that are on elagolix and the proportion of women that are having the significant bone mineral density loss that we can correlate with the fracture risk over time. So it's sort of outside of the model, but it's a really good question because, yeah, I can show